getting this reputation about giving talks that are about to screw you up. So here's a sequel for you. So I am an emergency doctor who's passionate and loves esoteric bedside medicine. I'm going to give you an old-fashioned talk, okay? This is a rare diagnosis, about 5 in 100,000, and it is a bad diagnosis, killing about 15 to 30% of its patients. But it needs a new brand. We need to rebrand endocarditis. Now, on nearly the eve of the 150th anniversary of my great country, we recognize the most famous physician, William Osler, who talked about the chronic, boring nature of endocarditis, the weak, the fatigued, the malaised. What I'm going to do is make it sexy again. It's a big task, and I don't mean to slight William by any means, but that's what we need to do. We are going to talk about the who, the how, the why, and the what. And with who, you need to think about who gets this, who are the usual presentations, and what kind of constellation of symptoms they present with. So we're going to start with 4 suspects. 2 of them are usual, 2 of them are unusual, and then we're going to talk about 4 presentations of things you really need to know in the rebranding, in the sexification of endocarditis. If you've had a valve replacement and you show up to my emergency department, presuming you have not sprained your ankle, my assumption is you have endocarditis when you walk in the door. I don't care if it's a tissue, if it's bioprosthetic, if some interventionist throws it in your groin and you have a TAVI. At the end of the day, your risk of endo is about 1% per year. A valve replacement plus fever is endocarditis. A valve replacement plus feeling like shit is also endocarditis. You cannot ignore valve patients. They always are badness. Usual suspect number 2, the shooter. 15% of people who shoot up IV drugs who come into the emerge with a fever have endocarditis. A great majority of them are bacteremic as well. If you look at IV drug users, the rate of endocarditis is about 2 to 5% per year. You need to respect your shooters. They all need to come into the hospital when they have a fever. You might not like them, but their disease is bad. Now let's focus on some non-usual suspects. And let's focus on the non-bacterial thrombotic endocarditis, merantic endocarditis, the Greek for wasting away. We are looking after more cancer patients than ever. This is a thrombotic complication of cancer that we don't think about because it's not a DVT or a PE, but they clot off their valve and they get a thrombotic endocarditis, especially the adeno-CA patients. The last unusual suspect is your lupus patient. Whether it's myo or peri or endocarditis, this disease screws up your heart. They get something called Liebman-Sachs endocarditis, and this is related to their antiphospholipid syndrome. They have a hypercoagulable state that picks off their valves. 4 suspects. Now let's talk about how they present. What you should realize is that I don't give a talk without an association. So just like we talked about chest pain plus 1 last year, this year we're going to talk about fever plus 1. And these are key recognitions that you have to make. The brain, a stroke. If you're young and you've had a stroke, you need to keep endocarditis on your radar. This is going to be an embolic infarct, and it's going to affect your MCA. When you look at embolisms with endocarditis, the key is you need to catch the embolic phenomenon. 65% of the time, that's a CNS problem, and 23% of the time, they're going to present as stroke. Catch the embolism. think about MCA stroke with a fever being endocarditis. Back pain plus fever. Now, osteomyelitis in the spine is extremely different than some sucky osteomyelitis of your foot. We're not talking about a diabetic foot infection. We're talking about osteomyelitis of your spine. That is a hematogeneously spread infection that is often a complication and sequelae of endocarditis. Back pain plus fever needs advanced imaging and needs you to think about endocarditis. Heart failure. Pretty damn boring, eh? Heart failure. Well, what if I told you this is a heart failure virgin? Even by spicing it up with that word. If you have heart failure plus fever, and I'm not talking about your grandfather from the nursing home who comes in with, I don't know, does he have pneumonia? Does he have heart failure? I'm talking about a 40-year-old who comes in with heart failure and a fever. Endocarditis is the big thing here. And interesting, this is the primary indication to see a cardiac surgeon when we know that you have acute aortic insufficiency with an unprepared ventricle. You go into heart failure, and it's badness. It's a bad form of endo. This is almost embarrassing to show you guys. I mean, if you think about first-degree heart block, no one even wanted to take credit for it, right? Where were Wanky back and Mobitz here, right? No one. We've been blowing off first-degree heart block for so long, it's bullshit, right? First-degree block, who cares? You show it to your med students just to see that they know it, but you don't care. Well, you have to care. Because if you have a heart block and you have a fever in the setting of endocarditis, this is highly specific for a perivalvular abscess. Use electrocardiograms as a sense to prognosticate the pathway of your endo. If someone comes in and they have normal sinus and then they switch into something as sucky as first-degree heart block, and they get a fever and a murmur, you know that's a surgical indication, a perivalvular abscess. For presentations, for patients, now you need to know how to examine every patient you see. I'm a simple guy. I'm going to keep things very simple. Up to 95% of people with endocarditis have fever. That is so easy. Every person who has endocarditis who comes to your shop with a fever, or anyone with a fever who comes in has endocarditis in your mind. You have to think about it in the same way that you have to think about what you don't want it to be. You don't want them to have meningitis, you don't want them to have malaria, and you don't want them to have endocarditis. Keep fever on the radar of all your patients. That's how you make the diagnosis. Dust off your stethoscope. I apologize to all the ultrasound folk here. You still need this. And you need to do this because up to 90% of patients with endocarditis have murmurs. It seems like the only people detecting murmurs these days are the med students who take 2 hours to examine the patients. We need to actually listen to people's chests. We know that in really acute, really sick endo, about a third of patients won't have murmurs. But if you don't listen, you won't hear. And what about this crap? Sorry, William, but at the end of the day, all these classical things that I've been looking for years upon edge occur about 5% of the time. It's time to devalue the classic vascular phenomenon of endocarditis. Raw spots? Are you kidding me? When's the last time I've actually been able to look at a fundi? I mean, oh yes, those are classic retinal hemorrhages with a pale white spot. Yeah, I can't even see in his eyes. Stop looking and start valuing those. Value the teeth because they're much easier to see with an otoscope or an ophthalmoscope. A dental procedure in the last 2 weeks is highly suggestive in the right patient. Ask about their dental visits and just look at their gross mouths. So we've talked about who gets it, how to examine for it. So why the hell do we keep missing this? And it really comes down to one major principle: the gospel of blood cultures, the bane of our existence. We do them too often, and we sure as hell don't know what to do with them when they come back. And I'm going to make things simple. 3 sets, 3 sites. Got it? 3 sets, 3 sites. There are some naysayers. You know, there are often people say, oh, is it okay if we do 1 set? No. It's never 1 set. You either do 0 or you do 3. You go looking for this. And the current guidelines will tell you if you're looking for endo, you want to make sure your first and third are separated by at least an hour. Okay? We get culture-negative endocarditis. About 5% of the time, we don't grow the bug. And half of the time, that's due to the fact that some putz has given antibiotic prior. The other half is it's just because of a real fastidious organism like the Hasek species. You have to resist the temptation of giving antibiotics. If you have a really sick patient, you maybe want to wait an hour at tops, 40, 30 minutes, an hour at tops. Try to get those cultures. Nothing makes an ID doc happier than obtaining positive blood cultures. Easy one, and I got a bunch of keeners in the front row. You guys all know what this is? It's obvious. Start with the keeners, front row. Okay, what if I told you this was Elizabeth Kingia meningoseptica? It sounds bad, right? It sounds quite bad. What if I told you this was Strep galiticus? You know, the organism formerly known as Strep bovis? It doesn't ring a bell? Well, if it doesn't ring a bell, it shouldn't, because I don't have a clue what either of those are. But I can tell you how I'm going to find out. I'm going to Google it. I'm going to wiki it, I'm going to Google it, or I'm going to phone a friend. Because if I look those up, there are 2 organisms responsible for endocarditis. You need to look it up if you don't know. Don't ignore it. And you certainly need to have an approach to another previously useless organism called coag-negative staph. I've been blowing this bad boy off since med school, right? 82% of the time it's a contaminant. Blow it off. Who cares, right? I'll tell you why you should care. If you have a valve replacement, 25% of the endocarditis caused in patients with valve replacements are secondary to coag-negative staph. It's the second most common organism responsible for endocarditis in that subgroup. So coag-negative staph plus valve replacement equals endocarditis. So when you get that blood culture, you need to look up their past medical history. And often that patient is not before you. He or she has gone home. And you need to have an approach to the other big part, which is all those contaminants we've ignored. If you have coag-negative staph and you're just like you and I, and you don't have a mechanical valve, you have to realize that there's one organism to look for. And the ID nerds will call it slug, Staphylogenesis. This is the one organism that causes endocarditis in people who are normal like you and me. So you can't blow off coag-negative staph provided your lab tests for slug species. You need that approach to coag-negative staph. I want to tell you a story about blood cultures. Any of you work with nurses? So I work with a nurse, and she got pneumonia. Blood work, x-ray, all supported. She got put on amoxicillin for pneumonia, very reasonable care. And the next day, the person at our shop who's responsible for looking at blood cultures gave her a call to say, you grew strep viridans in your blood, how are you feeling? Well, I feel great. The antibiotic's really working. And so the next day, when the second culture came back, the doctor said, you grew strep viridans in your blood, how are you feeling? Well, I feel great. Perfect, continue with what you're doing. So after 7 days and useless phone calls from my colleagues, she shows back up in the emerge and says, you know, I'm due to start work again. You guys have called me twice. Can I stop my antibiotics? It's been 7 days. And I looked back and I said, yeah, it's strep viridans. That doesn't cause endocarditis. If you don't know that, you can Google search it, but at the end of the day, it causes endocarditis. Sorry, it doesn't cause pneumonia. So what you got to realize is that if the bacteria doesn't fit the crime, you have to be nervous. And when you start seeing Staph aureus in urines of healthy people, not immunocompromised, catheterized ICU people, but when you see Staph aureus in the urine, when you see endocarditis bacteria in the blood, don't just go with the momentum of the diagnosis you want to do. What now? So you're not going to screw it up. What are you going to do when that diagnosis falls upon you? Whether you fluke it or it falls into your lap. You have to realize that antibiotics are the be-all and the end-all for every infection. However, this is the infectious disease emergency where you actually have time. You don't have to start antibiotics right away. In fact, there are no guidelines or no rules that give you anything to go by in terms of starting antibiotics. Wait. Wait for your cultures. I mean, that gram stain is going to come back in 4 to 6 hours. You're going to get some guidance. If you can't wait because either you're impatient or the patient isn't looking very well, think about the following antibiotic. This is a gram-positive problem. As an infectious disease specialist, you may never see gram-negative endocarditis in your entire career. You need to kill them with a gram-positive agent, and that is vancomycin, period. Vancomycin, if you had to pick one drug, is going to be what you're going to give. And if you're going to give a second one, you'll chase it with something like ceftriaxone. Vanco and Cef are going to kill everything if you're highly suspicious of endocarditis and you can't wait for culture results. You have to also realize that part of the management, whether we want to admit it or not, is we can't always be the cowboy heroes, and you do need cardiac surgery about 25% of the time. Endocarditis is a team approach that needs cardiologists, infectious disease docs, and cardiac surgery. Depending on where you work, you might not house all these specialties. So you want to be on the phone with your endocarditis team, and you need to think about the indications for surgery. You need to think about patients who come in with heart failure, perivalvular abscess, or patients who just aren't getting better or continue to shower embolic events and have strokes. So, can we rebrand endocarditis? Can we get over Osler and Janeway and all those lesions and look for better things? We got to remember the who's, the big four patients, your bacterial and non-bacterial thrombotic endocarditis. We got to think about the four presentations of fever and back pain, fever and heart failure, fever and stroke, and fever and rhythm disturbance. We need to think about how and keep this very simple. Look for fever, listen for murmur, and look at people's teeth and devalue the classics. We got to think about why we're missing this. We're not knowing what to do with cultures. 3 sets, 3 sites, Google, and have an approach to coag-negative staph. And lastly, get antibiotics when you need it and when you know it's the right time. Thank you very much for your time.
David, great talk. Thanks very much. We have time for one quick question. Karen?
There were multiple questions, but given the time, so the most important question that arose was the timing of antibiotics while you're taking the blood cultures.
So I think it's a really important thing, and the guidelines, whether you're American or European, and I'm neither, Karen, so I'll speak on my own terms, is that you ideally want to delay antibiotics and at least you have 3 sets or 3 sites. If you can wait an hour, I think that's in the best interest because it really prognosticates and it really allows you to pick the right drug and for the bug down the road. So if you can wait an hour, this is not evidence-based, it's expert opinion.